Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Shelley, would you like to introduce yourself?
Hi, I'm Shelly. I'm an undergrad from UMass Lowell interning here at the Blum Center.
Thank you. Today's program is part of our Dermatology Series, a special collaboration between the Blum Center and Mass General's Dermatology Department. Before I get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Shelley, who will introduce you all today's guest speaker.
Okay, so joining us today is Dr. Shinjita Das. Dr. Das is a board-certified dermatologist at Mass General and assistant professor in dermatology at Harvard Medical School. As technology director for the MGH Department of Dermatology, she has spearheaded the expansion of electronic consult program. Dr. Das leads and implements operational projects and patient education initiatives using technology-based solutions. She will be giving a talk on telemedicine today. Please join us in welcoming Dr. Das.
Thank you, Shelley and Amy, for the warm introduction. And I'm glad to be here this afternoon to speak to the group. We'll have an opportunity towards the end to have a bit more of an interactive session through the chat feature. Of course, everything that we share is going to be is anonymous and de-identified. We want to protect your identity, but we want to also keep this quite interactive. So let me go ahead and share my screen here. And just to make sure, Amy, can you see my screen? Perfect. All right. So today we're going to get to talk about telemedicine in what I call the post-pandemic era. So where do we go from here? A couple of disclosures. Let's see if the slides are going to go. But so a couple of disclosures. In addition to being faculty here at MGH, I also have a boutique medical consulting firm, Access Health Consultancy, and I'm an advisor to startups, including Skin Analytics. That being said, I have no relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services that we discuss within this presentation. Over the next 30 to 45 minutes, what I look forward to discussing with you all are four main pillars for the basis for our discussion towards the end. One, I want to spend some time discussing with you some of the major changes during the pandemic that have allowed us to widely use telemedicine. Because prior to March 2020, even as early as January 2020, telemedicine and telehealth were not the household names that they are now. Secondly, I want to share with you all the current state of telehealth and where we are right now as of spring 2024. Thirdly, to be able to discuss with you all the future considerations and challenges for telehealth. And finally, to recognize that really telehealth is part of the evolution of healthcare delivery, which is what I call omnichannel. And by omnichannel, I mean that healthcare delivery and the way that we deliver and receive healthcare is going to range a spectrum where that may be in person versus virtual, within the community versus within large hospital centers, and for us to start to think about how we think of the paradigm shift in the way that healthcare is delivered in this post-pandemic era. So as we get started, I wanted to give the group an opportunity over the next 30 to 45 seconds to share within the chat some of the pain points in healthcare. And those pain points can come from the perspective of you being perhaps a patient or a caretaker or a physician or nurse or social worker. But for all of us, we experience healthcare in some dimension. And so within the chat, I'll have you share some of the pain points that you've perhaps personally experienced or you've seen others experience. And with Amy and Shelley's help, I'll have those pain points read out loud for the group. And Amy, anything coming into the chat yet, or are folks still warming up this afternoon?
Still warming up and keeping an eye
All
on it.
right.
Nothing yet.
All right. Well, nothing yet. So I'll share some pain points that I've experienced. My perspective, of course, is coming from the perspective of a physician, but certainly also seeing my patients as well as family members and friends go through these as well. So some words that might come to mind include, wait times, meaning it can be really take a long time to get a doctor's appointment. It can be very difficult to triage, meaning to identify how do we get patients into the clinical care that they need at the time when that's needed. Cost is a big thing. So healthcare costs are rising. We live in an environment where the way that healthcare is paid for is called fee for service, which essentially means that whenever a medical service is provided, then there's a payment structure in place for that, irrespective of what the healthcare outcome is. Perhaps some other words that might come to mind are disparities in healthcare in terms of who is able to access healthcare. Also thinking about burnout. And burnout's a big word that's been within the healthcare space over the last several years, referring to clinicians burning out. But I think we, as individuals, whether we're patients or clinicians or in some way engaged with healthcare, there is a bit of burnout in terms of trying to navigate how to access care in a timely fashion. And certainly what we see from a healthcare provider's perspective is that the demand for healthcare services oftentimes exceeds the supply of doctors and nurses to be able to care for those patients. Another thing that I face as a physician are what we call no-shows, where we might be able to schedule a patient for an appointment, but for one reason or another, the patient might not cancel the appointment, but rather not even show up to that appointment. And we don't know that they're not going to come to the appointment until that appointment slot time has already passed. So sometimes there's a missed opportunity to capture a cancellation slot and be able to offer an appointment to the next patient who may need those services. And so for the next slide, when I think about all these pain points in healthcare, the next slide, I want to show an image. And just in the interest of full disclosure, I'm a dermatologist by training, so I feel like I wouldn't do justice to my specialty if I didn't include at least one dermatologic skin picture. But if you get queasy or a little bit grossed out easily, feel free to turn your eyes a moment. But the analogy that I think of for the current state of healthcare is almost like an inflamed cyst or boil where there's a lot of inflammation. And when you look at this picture, you feel like there's such swelling that at any point, this cyst in this case might rupture spontaneously and just create a mess. And so if we're able to manage this in a more controlled manner, so if a patient were to come to me before this cyst explodes, I'm able to numb that area and make a very precise surgical incision to allow the controlled release of the pus that's underneath. And so I use that as an analogy for the way I hope for us collectively to be thinking about how we improve healthcare delivery is to do it in a controlled manner rather than waiting for things to just explode and then try to put a Band-Aid over things. And so essentially, where that brings us is the fundamental challenge that we face in healthcare is delivering cost-conscious care across a clinical continuum while enhancing health outcomes. And by that, I mean that, we want to be aware of the cost of delivering care, but really be able to care for patients, whether they're at home or they're in the community or in the hospital, and to be able to do that while improving patients' health. And so that's really the biggest challenge that we face in healthcare. And one of the things that I've been studying and exploring even leading up to the pandemic is the possible value proposition for telemedicine. Now, before the pandemic, telemedicine was not a widely used form of healthcare delivery. Before the pandemic, most folks knew that you either show up at your doctor's office or the emergency room or an urgent care center, and then you see a clinician and get that one-to-one care. But one thing, when I like to at least hope for silver linings. And so I would say one of the potential silver linings of the pandemic is that we as society were challenged to think about how do we deliver care differently when we were constrained by not being able to be in person all the time during the pandemic. And so during the pandemic, there were several barriers that were removed to allow telemedicine adoption. So looking at this slide here, what we're seeing is that in 2020, January and February 2020, the use of telemedicine technology was essentially flat at 0% utilization. Now, that spiked dramatically with the lockdowns. And frankly, it's my brain has a hard time processing that this was now 4 years ago that the pandemic started. But when we think back to that time, there was an just like exponential rise in the utilization of telemedicine. And then what we saw is that as we opened back up for in-person visits towards the middle of 2020, the utilization of telemedicine started to fall, but didn't go all the way back down to 0. And so we think of it as being 38 times the utilization prior to the pandemic, although 38 times a very small number is still very small utilization. But it opened the door for thinking about a different modality of care delivery. Now, the pandemic happened, but the reason we were able to legally provide telemedicine as a service was because the laws around telemedicine utilization were loosened to allow that. And what do I mean by that? Well, first of all, during the pandemic, we were allowed to bill insurance for telemedicine and get reimbursed and get paid for telemedicine visits the way that we get paid for office visits. So then that created a formal pathway for us to provide those services. Secondly, we were able to utilize technology in a new way. And what I mean by that is previously telemedicine was only allowed if a patient was perhaps already at a medical center where there perhaps was not a specialist, and they had to log into that clinic's camera and computer system to have a virtual visit with a doctor who might be elsewhere. But now we were able to use technology such as our smartphones. So literally in the palms of our hands or on laptops, we were able to utilize the technologies that were there. And then finally, one thing that we were also allowed to do was to practice medicine across state lines. So for those of you who aren't familiar with how medical licensing works, any medical provider who is providing services has to be licensed in the state in which they're practicing and the state in which the patient resides. So for me, as a Massachusetts licensed doctor, I can only look after and care for patients who are living in or residing within Massachusetts. So I can't have a Massachusetts license and then provide medical care to a patient in California. So temporarily during the pandemic, this restriction was loosened, and it allowed us to continue providing continuity of care for patients. And in my practice, that was quite relevant because I look after a lot of students who are college age students who perhaps whose families live out of state, but the students live in Massachusetts for college. But when the shutdowns happened, the students were sent home back to their home states, but we were able to provide that continuity of care. And during the pandemic, also preferences shifted. So we were in a mode of social distancing, and just the nature of the pandemic really altered our preferences. And as a consequence, we also had to adapt our clinical workflows in order to be able to practice telemedicine and shift the way that our delivery was performed. And so what this means is there were some regulatory changes that took place during the pandemic, and this was led by CMS, which stands for the Centers for Medicare and Medicaid Policies. And so this is the federal governing body that really sets the tone for the laws around the way that healthcare is delivered from the insurance standpoint. And oftentimes, based on these guidelines, that's how private insurance companies set their standards for what's covered. So essentially what CMS allowed us during the pandemic was for the originating site, meaning where the patient is located, could be anywhere, including the patient's home. Prior to the pandemic, patients either had to live in a rural, underserved area, and in those scenarios, they had to actually go to a community health center, like a physical building, to do that. Whereas during the pandemic, patients could be at home and still participate in telemedicine. As I alluded to, telehealth was allowed to be conducted through a smartphone rather than having to use clinic or hospital equipment. Another feature that was removed was that there was no longer the requirement for an existing relationship. So prior to the pandemic, the only way that a virtual visit could be conducted is if the patient and doctor had previously met in person before and had an existing therapeutic relationship. Now, what we were allowed to do is even if the patient had never seen a given doctor, they could still establish a therapeutic relationship. And then finally, there was, as I alluded to, reimbursement that was loosened, where there was allowance for payment parity. And what that means is that the insurance companies would reimburse the clinics and the doctors and the hospitals the same amount whether the visit was a virtual visit as well as whether it was like an in-person visit. So they were be able to used interchangeably as appropriate. So certainly not all cases are appropriate for a virtual visit, but when it was safe to do so, then the insurance companies would pay the same for it. Furthermore, there were new allowable services during the pandemic that were not allowed before. And these included emergency department visits that could be conducted virtually, home visits, as well as PT or physical therapy, OT or occupational therapy, and SPT, which is speech and language pathology. Also allowable services include hospice, home health, as well as inpatient rehabilitation. So what I'd like for you to take away from this slide is that essentially the chaos that the pandemic caused actually forced a new way to think about what types of services could be allowed by telemedicine. And so all of this happened during the immediate period after the pandemic broke loose. But what I want to share with you is where we are right now. So as of January 2024, what is the current state of telehealth here in the US? And so all these allowances that I talked to you about are called quote unquote waivers that were allowed during the pandemic. And so the waiver about geographic requirements, meaning that the patients and the doctors have to be in the same state, that waiver is still in place until the end of 2024. All eligible providers who participate in Medicare are still able to conduct their virtual visits through the end of 2024 with the payment parity. The site limitation, meaning, whether a virtual visit can happen when a patient is in their physical home rather than in a doctor's office, that waiver is still in place. And some services are still allowing audio only. What we've seen a shift towards, though, is that virtual visits, increasingly, in order to count as a true virtual visit, does require that the doctor and the patient have a face-to-face, whether it's through a Zoom format or a FaceTime, but using a secure platform to have that visit. And then finally, that expanded list of eligible services has largely remained intact, but what we'll see is as we go into 2025, what services will continue to be covered versus if there's some services that are removed from allowance. And so essentially what that translates to is through December 31st of 2020, all patients can get telehealth wherever they're located. They don't need to be at an originating site, meaning they don't have to be in a doctor's office, and there aren't any geographic restrictions. That being said, the doctor still needs to be licensed in the state where the patient is, and so that's something to bear in mind. So let's move here. And so when we think about, as we emerge from the pandemic, what are some of the concerns that we would need to really keep a close eye on? And so something that's key here is really to make sure that we're closely monitoring patient privacy, security, data, and tracking. And so what this means is moving beyond HIPAA, which is the standard for patient privacy that medical institutions have to abide by, and really looking at efforts to make sure that the information that's being shared by patients, especially electronically, is protected in a way that it cannot be exploited for profit. Furthermore, there's efforts in progress to develop guidelines for how we apply artificial intelligence within the context of telemedicine. And so this is really an area that over the coming years will better understand what role AI plays in healthcare delivery, and of course, the responsibilities that all of the stakeholders have when using AI. And those stakeholders range from the developers of the AI algorithms, as well as the clinicians who are utilizing it, as well as the health centers, and even patients, really understanding what we're getting into when we use AI. And then finally, one thing that I alluded to is thinking about the way that telehealth services are extended beyond state borders. So again, for me as a Massachusetts licensed doctor, I'm only allowed to see patients who are actively in Massachusetts. And so there's actually an active lawsuit in place where a physician who is a very specialized physician and has patients who come from out of state is suing the New Jersey State Board of Medical Examiners. And the lawsuit really revolves around the fact that this doctor, who provides a very specialized service, is really petitioning for wanting to perform telemedicine to maintain continuity of care. But because that patient lives in New Jersey and this doctor lives in Massachusetts, technically it is illegal for that doctor to provide telemedicine. And it's illegal to the point where if that doctor provides a service, it could be considered a criminal offense. And where this federal case is going is really looking at it from the perspective of the fact that if there's a requirement for licensing of an out-of-state provider, that may be violating the US Constitution. And the reason I'm really emphasizing this particular case is because as this lawsuit emerges and as we start to see what precedent is set from it, it may offer us better light into understanding what licensing will look like across state borders. Because right now, like I said, if that doctor who is licensed in Massachusetts but does not have a New Jersey license, if she provides a telemedicine service when her patient is in New Jersey, which is the patient's home, she's potentially at risk for a criminal investigation and potentially going to jail for trying to be a doctor and take care of her patients. So this is something really important for us all to keep our finger on the pulse of. So to summarize in a different way, in terms of the current state of telehealth, when we're looking at the payer laws, and when we say payer, that means insurance company, insurance payer. Right now, where we stand is that all 50 states, as well as Washington, D.C., reimburse for live video virtual visits. Now, a subset of those, 43 of those practices, states will reimburse somewhat for audio only. So if a patient perhaps doesn't have access to a computer or a smartphone and can only conduct the visit in audio, meaning a telephone visit, then 43 states have some rules around reimbursement. 33 states reimburse for some store and forward telemedicine. And store and forward is a type of telemedicine that's different from the virtual visits or Zoom visits that we're accustomed to. And what store and forward means is that a patient may fill out a questionnaire or submit photographs of a concern that they have and then forward that to their doctor. And then at a later time, the doctor may respond. And so it's much more like an email communication, but in a formalized way. 43 states have laws that require private payers to cover telemedicine. And then 37 states have some reimbursement for RPM, which stands for Remote Patient Monitoring. And remote patient monitoring might be things like reimbursing for remote monitoring of one's blood glucose if someone is diabetic, or remote monitoring of someone's blood pressure in order to make adjustments to their blood pressure medicines. And so other formats might be if a patient is participating in home hospital type of service where they actually go home and they have are hooked up to different, for example, EKG or other sensing devices to be able to have that information relayed to the clinical team so that the clinical team can make decisions about the patient's care. So there are some states, but not all, who will reimburse for it. And I wanted to, use that as a springboard for sharing a trend that we've seen in primary care that leads me to believe that we may be using more and more telemedicine or even urgent care centers moving forward. So one trend that's been emerging over the last decade or so is the utilization of primary care doctors. So essentially, what we've seen is between 2008 to 2016, so this is well before the pandemic even started, that there was almost a 50% decrease in visit to a primary care doctor for low acuity conditions. So a low acuity condition might be a cough or a cold or a minor rash, for example. And what that means is that largest decline happened in individuals who are younger adults, those who are generally healthy and didn't have chronic conditions, and then also, unfortunately, for those who are low income. And so for low income individuals, It's a bit unclear if that's because they weren't able to access care because of the timing at which the appointment slots were available or what. So we're seeing a decrease in the utilization of primary care clinics. And we're seeing also that increasingly more of the cost of healthcare is being borne by the patients themselves, having to pay out of pocket. And then finally, what we're seeing is that the decrease in primary care utilization is almost exactly offset by the increase in visits to urgent care clinics. So you might think about urgent care clinics as being freestanding clinics within the community or perhaps within retail pharmacies and such. And so what we're noticing is that there's generally a shift where patients who are generally younger, don't have chronic conditions, or perhaps are lower income individuals who, instead of coming to a traditional doctor's office, are then shifting themselves to urgent care. And these urgent care centers tend to be in areas that are in the neighborhoods of where patients live. And so this is an interesting trend that was already starting before the telemedicine trend started with the pandemic. And so one of the things that we think about is, well, how is telemedicine going to help us? Because if we're just doing a one-to-one replacement of just replacing an office visit with a virtual visit that still requires the same use of time, are we making an impact? And so the value in telehealth, I believe, really lies in twofold. So one is the ability to scale that, to really scale it beyond the boundaries of a brick and mortar space, but also the network effect that it creates. And it allows us, with telehealth to have more connectedness. And so what we do is we start to evolve from a one-to-one model, which, by the way, I think there are certainly plenty of scenarios where you still need one-to-one care, and that's not going away. But for scenarios where it's safe to do so, there's an opportunity to have more of a connectedness. And so what that might mean is that when you've got the patient at the center, then that patient is connected to their different providers, whether that's in a clinical setting, as well as non-clinical settings. And that really opens the door for the network effect where care could be delivered at home, where using telemedicine and technology, we may be able to track patient outcomes and try to make sure that we're improving the metrics that we're looking for. Also, an opportunity for us to do predictive analytics. And what I mean by that is allowing us to study more broadly. Well, if there's patients with similar characteristics, are there ways for us to predict how those patients might respond to a specific treatment approach? And can we use that global information to help the individual? And so essentially what we're really aiming for is to move from a trial and error or even a one size fits all approach to being more precise and precise in the treatments that we offer our patients. And so I use precision in quotes because oftentimes we think about precision medicine more in the genomics and biotech side. But here I'm thinking about precision in terms of using the data that we collect from telehealth to be able to make some sort of inferences about how we may be better able to serve patients. And so with that network is being expanded because we have key players in healthcare that are expanding out. And some of these players are known players in the space, but over the last 5 to 10 years, we've seen that playing field open up a bit. So the patients are at the center of the care that we're delivering, and certainly surrounding them, there's the clinicians and hospitals, insurance payers, as well as pharmacies and medical device companies, and even biopharma who are developing newer drugs for patients. But the newest entrant into this space are technology companies. And so in the chat, I'd love if some of you could share some of the technology companies that you've observed from your perspective getting into the healthcare arena. Anything showing up on your end, Amy?
There isn't, but while we wait for any responses, there are a couple of other questions if you want
Sure.
to help
Yes. Yep.
answer. One being, are there any programs available to patients who are interested in telemedicine but don't have access to the technology needed, for instance, the devices or internet connection?
So that right now can be the trickiest thing in terms of how do you get access to it. And I know from a government perspective, there's some efforts really to be able to bring internet access to those who may not already have it. And so there's efforts in place to expand that infrastructure. And I believe that that infrastructure starts with first increasing internet connectivity and speeds, and then being able to bring some of that to patients. At this point, probably the best way to utilize telemedicine for individuals who don't have access to a computer or internet may actually end up being going to a clinical site where there is that technology and then doing the virtual visit through there. And an example of that, which we actually participate in here at NGH, is, for example, telemedicine with patients in Nantucket Island, for example. And in this scenario, it's not necessarily that the patient might not have access to the internet technology, but rather that the doctors aren't always able to get to Nantucket Island. And so in those scenarios, the patients actually come to the clinic where there's a nurse who helps to facilitate that visit by being able to take photos and video of the patient's skin concern in real time while the dermatologist is on the other end and be able to do that. And so this is a place where community health centers and even retailers may be participating in a way to fill that gap between the technology and infrastructure within the patient's home and then helping them to get connected.
Thank you. And you had talked about providers being only able to offer telemedicine in the state they hold licenses for. Do you see this changing anywhere in the near future, starting in 2025?
I don't see it happening in 2025. And the reason for that is medical licensure is actually managed at a state to state level. And one of the arguments for keeping it at the state level for licensure is that theoretically there's a concern that if doctors and nurses can get licensed out of state, could there be players who enter in and potentially create a competitive space where then the doctors living in a given state aren't able to compete from a access standpoint. I don't know if that makes sense, but basically the idea is that in order to do those state licensing, it's allowing to a way to ensure that the patients in that state, as well as the doctors and nurses in that state, are able to provide those services. That being said, I do believe that over the coming years, that this licensing issue will really have to be examined because right now it's super cumbersome for a doctor or nurse to have to get licensed in multiple different states, and there's no standardized way of doing that. And I truly do believe that the way that we provide the best care and continuity of care is allowing the free flow of that information. And patients should have a choice of their clinicians. And so if the world expert in XYZ disease lives in Montana, but not in the state that you're in, for example, then each individual should have the right to be able to seek that care there. All right. So in terms of the technology companies, some of the companies you might have come across who are playing in healthcare include Google or Amazon. We're also seeing retailers like Walmart and CVS and Walgreens getting into the healthcare space. And so why this is really important to keep in mind is that these technology companies, as they're playing a bigger role, these companies are virtual first and are able to, and also have a client population who could potentially become a patient population. And so that's something to bear in mind. And so, especially as the technology companies are trying to get more involved in healthcare, it really opens the door for home-based healthcare delivery. And so telemedicine is one way of doing that, but also the rise of connected devices. So nowadays, many people wear a smartwatch perhaps the scale is a smart scale where you can hop on the scale and then the weight that's on the scale is then automatically delivered to an app, and then you can track it electronically. There's also increasing look at digital biomarkers. So beyond just blood tests, looking at biomarkers that might predict disease. An example of this is there's some research that suggests that one's risk for Alzheimer's might be predictable through the speed or cadence of one's speech, meaning the way that you're talking. And that over time, over years and decades, if there's a change in speech patterns, that might predict a risk for Alzheimer's years before the actual clinical diagnosis is made. And then with home-based healthcare delivery, the door is wide open for possible home lab testing. And in fact, there was a natural test of this when patients were able to receive home COVID tests that were mailed by the US federal government. So there was a way for us to start thinking about doing lab testing at home. And then we've briefly touched on remote patient monitoring. And then there's also a renewed interest in looking at digital therapeutics. So are there ways to use technology to treat conditions rather than true pills or injectable medicines? And an example of this might be for patients who have ADHD, or attention deficit hyperactivity disorder, that they may respond to certain digital video games that are clinically designed to help with their attention span, and thinking about that as a treatment option, either with or without pills. And an offshoot of that has also involved digital connectivity for traditional medicines. And then finally, as I alluded to, home hospital. So the idea being that whenever it's safe to do so, once a patient is stabilized, can most of the recuperation happen at home with close monitoring through remote devices. Now, this is all very exciting where things are potentially going, but one of the biggest challenges that we face with telehealth is that it potentially fragments healthcare. So if a patient has a primary care doctor in Boston, for example, but then they go to an urgent care center for a cut to get antibiotics because they're concerned about a skin infection, but then they go online to get a direct-to-consumer telemedicine consult for acne, for example. And so when patients are receiving care in many different formats, and particularly if it's telehealth in different settings, that can fragment it. And so one of the biggest challenges that we face is that the information does not flow freely across health systems or provider. And so one of the things that we really need to think about and focus on is the need for telehealth to follow patients across the care continuum. And so that might involve really looking at what does it mean to create a personal health record rather than all of the information sitting in one hospital systems or one healthcare systems servers. Is there a way for us to make sure the information is portable for the patient so that whether the patient is in one location or another, that information is accessible to the clinicians at that site? And I think this is even more important now than ever because we're such a nomadic society compared to even a generation ago. And so people are traveling more, they're more mobile in general. So something to bear in mind. And really thinking about what that personal health record looks like, because there's different aspects of care. There might be acute or self-limited conditions that just need to be addressed, but thankfully are not life-threatening. There are scenarios that require chronic care management. So for example, patients who might have diabetes or high blood pressure who are on medications that require monitoring. And then finally, thinking about acute conditions that could be life-threatening and have to be addressed immediately. And so all of these have different levels of acuity, and having a personal health record could be very helpful. And even having personal health records could help us to think about how we take clinical trials on drugs and be able to extend them to real world application and experience. And so something for us as providers, as patients, as caretakers to be thinking about and brainstorming and sharing amongst ourselves to really improve and evolve on. And then, of course, with telehealth, there's many different vendors, and so that can really fragment the care. And so you've got telehealth that's within hospital systems, telehealth that's being delivered by tech companies who, have membership style offerings that then are capturing patients that way. And so that can really fragment things a bit. And so one of the things that we think about is, well, okay, we've got this fragmentation, but what are some of the types of technologies that might be able to help consolidate or enhance this home-based virtual care that we've been talking about? And so some of these can include artificial intelligence or augmented or virtual reality, remote monitoring devices, really improving internet network connectivity. And so that was a question that came up earlier is, well, what happens if there are some patients who don't have access to the infrastructure? And that's something that we more on a macro federal level really have to look at. What does it look like to build out a strong internet network? And then the other aspect of this is looking at our standards and frameworks for interoperability. And so Health Level 7 or HL7 is a framework or standard for interoperability. And what I mean by that is it's a coding platform that allows information to be exchanged, integrated, shared, and retrieval of health information across systems. And so this is a standard that if it's adopted broadly, which it has been, but really being able to launch it more broadly can be helpful for making sure that that information across different fragmented locales of care delivery can be connected and accessed when it's most important for the patient. And so when we think about this, what I want to leave you with in the last couple of slides is that the healthcare delivery of the future is omnichannel. And what I mean by that is a generation ago, healthcare was delivered in person. So you go to the doctor's office, you go to the hospital. But we're seeing a shift in the different generations where there's an increasing shift and interest in millennials and Gen Z in using technologies such as mobile apps and patient portals, online chats, text messaging. So some of this technology, rather than, with Gen X and boomers, there's more of an interest in talking to a real person or going in person to have that conversation. And so as we see this shift, we realize that healthcare really needs to serve multiple generations. And so right now, what we see is really being able to cover that spectrum of virtual as well as in person. And this shift may even shift even further towards virtual as the Gen Z and millennials who are more technology native start to get older and develop more chronic diseases that require management over time. And so the different formats that care can be delivered are through phone, email, text messaging, mobile apps, automated phone, as well as chats. And so with omnichannel healthcare, really what we're aiming for is for healthcare to be delivered in different locations. And so that means perhaps for virtual care, we're using that to triage and to understand, okay, is this something that can be safely managed remotely? Does the patient need to come into the office? Or can we have a virtual visit and be able to offer a prescription or management approach through that virtual visit? Typically, this will be also for low acuity, non-life-threatening conditions, as well as management of chronic disease. There also may be a need for in-person visits that can range from community centers like freestanding clinics for, again, non-life-threatening conditions, or perhaps if something physical needs to be done, like an imaging test or a blood work that needs to be done. Although we might see in the next few years that blood work can be done at home. This technology is still very young, but something for us to think about. And then finally, when we think about high acuity, potentially life-threatening conditions, or times when patients need surgery, then perhaps hospitals or outpatient hospitals may be helpful. But there's a big shift towards thinking about home hospital for more of that recovery and continuous monitoring aspect of things. And so what we're seeing is a shift towards providing care at home in as safe a way as possible. And so with that final slide, I want to leave a minute or two to get thoughts of the audience in terms of, what you wish for healthcare in the future, because we've all experienced it in some way, whether it's as a patient, as a caretaker, as a friend, as a clinician. We've all experienced healthcare in some way. And so thinking about, well, what would you wish for a better, more efficient healthcare delivery?
While we wait to see what people's thoughts are, we have a question regarding Epic. What are your thoughts on Epic in regards to telemedicine and sharing between healthcare systems?
So with Epic specifically, and so this is a large electronic medical record system that has been adopted by many health centers. And so Epic has a feature that integrates telemedicine option within the scheduling platform. And so for health systems that use Epic, there's a feature that when it's activated, we can conduct virtual visits straight through Epic. And the reason that's helpful is because when we're within the electronic medical record, we have access to the patient's charts, can review that when we're conducting a virtual visit. And then for health systems that are all within that same electronic medical record system, there are ways to share that information where it's automatically accessible, with the caveat that the patient has to sign a medical release that when they give permission, the information can be accessed. And oftentimes, in my clinic, I can access that information if the patient's right next to me and they said, you know what, I got care at outside of Boston. If we go into Epic, we can see those other records. And for me to access it, I can have the patient sign an electronic consent right then and there, allowing me to access those records. So we're definitely moving in the right direction with it. But where the trouble comes from is perhaps two hospital systems might not be within the same electronic medical record system. So that's where some of the challenges arise in accessing the data when it's not the same EMR or electronic medical record.
Thank you. I don't see any additional comments.
Well, if any questions trickle through, feel free to email me, Amy. I will actually, if there's no further questions, I'll hop off because I am in the office, and so I'll be this morning at 7, I was doing virtual visits, and then this afternoon I'll be doing in-person visits. So certainly having virtual as an option allows us to be able to provide more access to patients. So I'm going to hop to clinic, but I really appreciate everyone's attention and really thank you for the opportunity to come speak to you guys today.
Thank you so much for your time. This was very helpful.
Thank you.
All right. Y'all be well. Take care. Take care. Bye.
And for those who joined today, thank you so much for joining us. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.